All right, so we'll get started. Thanks everyone for coming this evening to join us for the next instalment of the VRHC Speaker Series. It's great to have so many people back. This is the third session for our Victorian Rural Health Conference, and the topic for tonight is the Victorian Rural Generalist Pathway. So my name's Sky. I have the great privilege of being the Vice President of the Rural Doctors Association of Victoria at the moment. And before we start, I'd just like to acknowledge the traditional custodians of the land upon which we all live and work currently, all of the lands on which we live and work, and pay my respects and RDAV's respects to elders past, present and emerging. And we'd also actually like to extend that respect to any other First Nations people who might be joining us this evening. We have this evening a jam-packed panel for everyone. We've got here some great panelists who I'll introduce in a second. The way that the evening is going to work is that we are going to have both a section for providing information as well as plenty of time for you to ask your burning questions. The people on the screen that you can see in front of you, I'll ask them to provide a brief introduction of themselves. So first, we've actually got Dr. Dan Wilson. Dan, do you want to introduce yourself to everyone?
Hi everyone, thanks for the introduction there. My name's Dan. I'm a current rural generalist trainee training within the Grampians region, and I'm undertaking an advanced skill in women's health obstetrics. And I have some other interests, clinical interests in medical leadership, education, and transgender and sexual health.
Thanks, Dan. Next on the screen, we have Dr. Sue Harrison. Sue, are you happy to introduce yourself?
Yep. Hi, I'm Sue Harrison. I'm a GP in Echuca, where I've lived and worked as a rural generalist for the last 30-something years. My special skill training was in anaesthetics, and I still work regularly in the emergency department in both Echuca and Swan Hill, and supervise registrars as well as interns and medical students in my general practice.
Thanks, Sue. And last but certainly not least is Dr. Angela Stratton. Angela, would you love to say a few words about yourself?
Thanks, Sky. So I'm the statewide clinical lead for the Victorian Rural Generalist program. So thank you for inviting us to come along tonight. And I'm a rural generalist in Mount Beauty, Falls Creek. And although my special skill was obstetrics to begin with, I now work in remote medicine, in alpine medicine, and in the emergency department also at Albury-Wodonga Health, and you can see the lovely alpine region behind me in my backdrop.
Thanks, Angela. So the purpose of this evening is to hear some information, the latest information on the Victorian Rural Generalist Pathway, and we are really glad to have Angela with us to be able to provide us with some of that information, which she'll do shortly. And then there's a bit of an opportunity for everyone in the audience to get some insights into both the benefits, but also issues impacting on supervisors and registrars as part of the Rural Generalist program. Most importantly, though, we want to actually answer your questions. So please use the Q&A icon to submit your questions, and we will try to get through as many of them as we can. So without further ado, we'll hand over to Angela for a presentation and update on the Victorian Rural Generalist Pathway.
Thank you. I'll just share my screen. And yes, I second what Sky has said, that I really would like to make sure that we answer any questions that you have tonight. So please pop them in the chat bar, and Sky will flag them if we need it as we go along. Okay, so what is the VRGP? So as we've got quite a mix in the audience, I'd like to just focus on how we fit into the National Rural Generalist Pathway. So as you know, Professor Paul Worley was the first rural health, and now the Bruce Stewart has taken over from him. But part of their initial project was to start the National Rural Generalist Pathway and ensure that every state was working towards streamlining the training of rural generalists. We were actually very lucky in Victoria in that we already had a really strong program that was funded by the department, our State Department of Health anyway, and we was basically just had a few tweaks to pull it into part of the National Rural Generalist Pathway, and hence the Victorian Rural Generalist program was developed. So one of the things that we find as a real strength of our program is that we are regionally focused. So our state is broken up into 5 different rural regions, And although we have a statewide coordination unit that oversees the different regions, the program is really run on the ground. We with a focus on rural, what we have regional networks, which each of the smaller regional and sub-regional health services are represented on these regional networks. And what they do is they're helping to ensure that the training that's provided in their region is actually going to meet the workforce needs currently and in the future. Each of these regional networks does have a regional coordinator who will help trainees develop an individual training pathway that will work towards not only their own training, but help them be linked with a community that enables them to be able to practice the type of medicine they'd like to practice, but while matching those workforce needs of the town. So it's a really, I think it's a fantastic program and it's working really well. So as I mentioned, we have our regional coordinators, which are a real focus of our program, and they provide one-on-one case management, right from medical students who might be interested in becoming rural generalists or at least exploring a rural generalist career, through to interns and PGY2s, and then once anyone's applied onto rural generalist training with ACRM or VRHC21, we support both colleges. The coordinators can actually map out your training and help you I guess put it all together, because some of the times we know that with rural generalist training that the skills that you need for your community are actually quite unique, and therefore everybody's training journey is different, which we'll no doubt hear from Dan a little bit later, and the regional coordinators can help to make sure that your skill set, well, the training you get along the way and the skills that you obtain are what you need for your journey. To support the clinical lead, support the coordinators, we have clinical leads, 4 of them in the main disciplines or the most popular disciplines that we have, which is anaesthetics, obstetrics, emergency medicine, and pediatrics. We have a clinical lead, which I'm not sure if some of them have joined us here tonight, that works with the regional coordinators across the whole state and also provides some mentorship to trainees who are following that path in their advanced skill or might be interested in it. For the other advanced skills, such as palliative care, mental health, remote medicine, adult internal medicine, I look after those as a clinical lead in that field as well. All right, just a little bit on the governance structure, which I talked about before. So the overall framework for the VRGP was developed by the Department of Health, and I believe one of our workforce managers, Sonia's on here tonight as well. Our overall governance is actually run by the Statewide Reference Committee, which Rob Fair, your president of RDAV, is a member of, along with the members of the colleges, RWAVE, Department of Health, and the chairs of all the different regional networks, as well as the PHN. So that is the overall governance to ensure that we really are doing what we're trying to achieve, and that is to streamline and coordinate the training of rural generalists across the state. And then, as I said, we've got clinical leads, coordinators, all the way down to onto the ground with the regional networks and the coordinators. And here's a little map of our regions. If you're not quite exactly sure where those boundaries are, it's a bit of a visual for you. Now, this little infographic just wants to demonstrate that although our generalist program does have what we call a pure pathway, and that's from someone who, in theory, joins as a RG1 or an intern, and then they progress to a PGY2 or an RG2, and then heads into their core training, which with either college, and you can do your advanced skill either straight away, or you can go do some GP training in your primary care or some of your hospital, some more hospital training if you'd like to, and then come back and do your advanced skill. We're supportive of people anywhere along that pathway, and although you can enter at the start, we also have what's called lateral entry, which that means that people can join it at any one of those points, including someone who might already be an ACRM registrar or an RACGP registrar who would like to become part of our program and have the case management by the regional coordinators. We also enable a fellow GP pathway, which is primarily FRACGP fellows who would like to undertake the VRGP and do that advanced skill and core emergency training that takes people up to the rural generalist sort of difference level. However, we can also support ACRM fellows who may want to go on to do a second advanced skill as well. So if you'd like to know more, the absolute best place to go is to our website, and there's an online expression of interest form there that if you fill out, it actually helps to direct your query to the relevant regional coordinator, or if you're interested in more than one region, our statewide administrator can be in contact with you. And I did just want to flag a few key things at the moment, depending on where the different, I guess, demographics of our audience. So if we do have any medical students in with us at the moment, just be aware that all our RG1 or intern positions are in the VPRA match, which is open now and closes on the 3rd of June. And you can enter that during, via the PMCB website. Similarly, if you're a PGY2 and would like to become a rural generalist, then you can apply via the college of your choice, which is obviously AGPT for RACGP or ACRM, or you can also do the ACRM IP or RG100 when they start to open up, or RVTS. So all of those are supported on the VRGP program. Now, if you are already on the program or applying this year and would like to do an advanced skill, or perhaps you're registered in a GP clinic and would like to do an advanced skill for 2022, the applications for our match for that are on at the moment and close on the 4th of June. So there's information. I'm not going to go into all the details now, but just flag that they are open currently. And similarly, if you're already an RG trainee and want to know how you can be supported on our program, then please head to the website for that. Now, I did have a few other little things I just wanted to talk about just for those that might be interested. So we have, since we've started 12 months ago, done a complete revision of the RG Advanced guidelines and matching process for that. And one of the key changes is now really reserving those 47 state-funded training positions for RG trainees, which is we think is a really huge advantage and a great way forward for people wanting to get that additional skill. We've also revamped the Rural Generalist Consolidation Program. So that used to be known as the Consolidation of Skills Program. And that is really focusing on that year following your advanced skill training, whenever you might decide to do that, even if it's at the end of your training. And that's some additional funding that does, once again, supported from the state government, that enables trainees to maintain that advanced skill or transition to more independent practice in a smaller rural environment. And that pays for additional supervision, or perhaps you haven't quite finished your logbook, those sorts of things, to make sure that you're really able to use those skills. And then the final program that we've got running at the moment, which is another new one for this year, is a Rural Generalist Training and Education Grant. And there's two different streams for that. And without going into too much detail, basically that provides additional funding for trainees to basically support, perhaps if they're doing a diploma, some funding to that, or support smaller health services to actually employ rural generalist trainees to either utilise some of the advanced skills they've already got, or to work within perhaps urgent care or other environments that might not be able to be done under a VMO fee-for-service model. And then I've just got a list on there, which I won't read through all of them for you, of some of the other things that we've been doing, which is quite a lot, I think, in the last 12 months. It's pretty exciting what we've been doing in this space. All right, that's all I'm going to say, Sky, because I know I'd much rather be talking about what's actually the questions people have and directing it based on what people want to know. So I'll stop sharing my screen.
Thanks so much, Angela.
Go from there.
We're, as mentioned before, really privileged to have you here sharing all of that information with us, hot off the press. So thanks so much for doing that. Just a reminder to everyone, if you would like to ask a question, and any question is welcome, you can pop it into the chat or the Q&A function at the bottom of the screen, and we'd love to get your questions. So we're going to kick off now the panel portion of the evening, and maybe just to get things started while all of the attendees think of what they'd like to ask, can we just start by clarifying what actually is the difference between a rural generalist and a GP? Who would like to take that one? Angela, go.
Shall I take that one, given that's my bread and butter?
Yep,
so
absolutely.
The term rural generalist, or I guess rural generalists themselves are not new. they're what rural GPs have been doing since rural GPs existed. But it's basically a new term to differentiate the skill set that rural GPs working in those smaller towns do, which is primary care, secondary care, you know, admitting to their local hospital, emergency medicine, but providing that on call, but then also having some advanced training, which may be procedural, such as obstetrics or anaesthetics, or might not be. It might be palliative care or aged care, adult maternal medicine. And just distinguishing that from a doctor who perhaps works rurally, but solely in primary care, or may only have one or two of those skill sets. So it's really a new term for something that's always been there, but by creating that new term actually enables a dedicated training to make sure you've got those skills that you need to practice that sort of medicine. But Sue or Dan, do you want to add to that?
So Angela, I'd say that I would agree with you 100% that it's what most rural doctors have done. And when I first started in general practice, there were many rural generalists in northwestern Victoria, but they were a bit scary to me because I didn't feel that as at PGY3, I was ready to be that person. So back in the day, you took yourself off to the other side of the world to do whatever extra training you wanted, especially obstetrics and anaesthetics. And I just think it's a great thing that we're able to support people to do their training, especially if we're able to help them where they want to be living and working, so they don't have to pack their kids and their husband and whatever have to. Great experience, but it was hard work. Yeah.
Thanks, Sue. Anything that you wanted to add to that, Dan, at all?
No, I think that's fantastic for me.
Perfect. Well, Sue, we do have a question for you, which is what can supervisors do to support or better support rural generalist registrars? What would your advice be as somebody who's been supervising for quite some time?
So the first thing I think is that supervisors need to have an understanding of what rural generalist training is. And for many of us who've worked in practices where we've had VMO jobs, then that's relatively easy because we have a fair idea of what sort of skill set is going to need to be involved. But I'm aware of many of my colleagues who perhaps haven't had that same experience working as VMOs. So having an understanding of the multiple facets of rural generalism, and that hopefully will give people the opportunity to support their trainee towards their fellowship, whichever fellowship it might be. I'm really aware that at the moment MCCC, and we cover most of the rural parts of the state, having special sessions for supervisors in training them in the ACRM program. So ACRM program pretty much equals rural generalist training, and that might be something that supervisors find useful to answer some of those questions about how ACRM works, how the assessments work, so that we can support our registrars when they're involved in that training.
Thanks, Sue. Angela or Dan, did you want to add anything to that, I suppose, from the VRGP perspective or the trainee perspective around how you think that supervisors can best support trainees?
Angela, take the floor if you like, and then I'll go after you.
No, I actually agree with Sue, but I think being aware of the differences in RG training, whether it is with ACRM, as Sue said, so all ACRM trainees are training to be rural generalists. RACGP, you have the choice, so you can do your standard RACGP fellowship, or you can do the additional VRGP, which enables you to be the rural generalist qualification. So I think it's really important to understand the extra bits that are required for that, and then making sure that you facilitate those opportunities for your trainees to come along. So if you're doing something procedural or you're doing something extra, making sure that you invite them, have them there, and take that extra time to help them get those extra skills that they need. But Dan?
I would say to any potential supervisors or current supervisors, first of all, the current, thank you for what you do. Second of all, to anyone that is looking to improve their practice as a supervisor, is to continue to be flexible in your approach to adapt to that trainee's needs. Rural generalists, we're far from a homogenous group, and we all have very unique clinical desires, professional desires. And sometimes, even though Angela's image that she's put forward there looks really, really linear. A lot of VRGP trainees' journeys are very far from linear. It goes in and out of that pathway. I'll do something else for a bit and I'll come back in, and I'll go out and come back in. And it's about not only supervisors having the flexibility to respect and support that, but also then the program helping support the supervisors to do that as well. And I think supervisors already do a fantastic job of supporting their trainees.
Thanks, Angela.
And I'll just do one little shout out to jump in to put your hand up to be a mentor of a future RG as well. Sign up to Dr. Jump or one of the programs.
Sue, what were you going to?
Sky, the other thing I would have to say is that, you know, emergency medicine doesn't happen in hours. And so our supervisors and our trainees need to be prepared for the fact that they will be working in after hours. And sometimes, you know, a lot of rural generalist work is at the full scope of our practice, and sometimes that can seem a little bit scary. So being a supervisor means being there to actually support and supervise at all hours of the day and night, potentially. Yep. So that's a really important thing to take into account as well.
Yep. Thanks, Sue, for that. We've got some great questions coming through in the Q&A and in the chat. We've got a question from Holly, thanks Holly, who just wants to clarify, how does applying to be an RG with VRGP differ from applying to ACRM? Maybe Dan, did you want to take that one?
Yeah, thanks. I can appreciate, Holly, a lot of these terms and acronyms can be really quite confusing. So I hope I can clarify this for you. So ACRM and RACGP are the two professional bodies, colleges, that accredit and determine the training needs and determine the curriculum. So if you choose to train with ACRM, you will graduate from that program as a rural generalist. What VRGP is a funding and governance structure that's supported and delivered by the State Health Department to streamline and case manage trainees through that rural generalist journey, and it safely and helps articulate with either of the two colleges. So you could become a rural generalist either with RACGP or ACRM, entirely outside of any state-based rural generalist program, but I would highly encourage becoming part of the rural generalist program in your state, so here the VRGP, because you have greater access to financial support and also the mentoring and case management support. I hope that clarifies things.
Thanks, Dan. Anything that you wanted to add to that, Angela?
Yeah, I would. And Dan, you've done a wonderful job. We should get you on the payroll to explain what we do. I'm joking. But as someone who went through rural generalist training in Victoria before this program, I really did have to pave my own way to get the skills that I needed in order to fulfill that training. Now, it's not that any one person wasn't there to help me in a particular way. It's just the unique nature of actually having you need to work for different employers to get all the different skills that you need. And sometimes you need to go back in from primary care into a completely different health service, and then you're not employed by that health service to get those skills. And there's this back and forwards that you need. Now, that was quite disjointed, whereas what the VRGP now is doing by having that case management with your regional coordinator, you've got one person who knows exactly what your training needs are, what you would like to get for that town that you're doing, and they just streamline it all. And I will say that a lot of the changes that we've made have been based on talking to lots of people who've been through experiences like mine. Where are the holes? Were people slipping through? And what did we need to do to really make this process work? And we'd love to hear more if there's more things that we can be doing. But that's really the difference.
Absolutely. We've got an excellent question from Lauren in the chat. Thank you, Lauren. She says, thanks for a great session. Non-GP specialist colleges are looking to the regional hospitals in Victoria for training options for their specialties to grow their own in the region so that specialists will stay in the regions. There is the potential for advanced training post for RG to be reduced in number or to have reduced clinical exposure due to competition from other specialty trainees, e.g. emergency medicine, paediatrics, anaesthetics, adult internal medicine, psychiatry. Are you seeing this trend, and what is occurring to engage with the non-GP specialty colleges? Who'd like to kick us off with that one?
I'm very happy to answer that, but I'm actually personally would love to hear Dan's experience as a trainee first. Have you been impacted by that, Dan? And then I'll add the, I guess, the governance answer.
Sure. It's such a topical question, Lauren. I think it's a really real threat that could impose upon possible opportunities for rural generalists. What I would suggest is that the two processes need to happen collaboratively and side by side. Rural generalists and non-rural generalist specialists offer complementary services that can enhance a service. And from my experience, I haven't experienced any role for out-competing for my training. In the region where I work and where I'm currently employed, that role is well understood and very highly supported. But those conversations around supporting particular RG training positions need to be continued to be supported. And that's, of course, part of Angela's role to help start and continue those conversations with health services so that we can assure those positions for RG trainees, but also collaborate with the non-RG specialists too.
Yeah, absolutely, Dan, and that's what we're already doing. We're very aware of this, and we realise that they complement each other rather than compete with each other. And one of the things about the regional networks is that the regional health services, I think, are developing a greater understanding of the role in which they play to support the entire region. So, I mean, historically, there's been a bit more of an inward focus from some of the regional centres to look at their own hospital and their own workforce needs. But by bringing the smaller health services and the regional centres together, and they get to hear and what the smaller health services need, they're really developing this understanding of the role that they play in this crucial role in training the RGs for the skills that they need to take out to those smaller centres, but then seeing the benefit of the flow on for that. If they upskill the RGs and facilitate more RGs going out to the smaller towns, that actually improves their referrals, the decreased numbers coming into ED, and there's a real benefit to that. So we actually think the regional centres are embracing it. We're having really honest conversations about with regional centres about, yes, well, actually, we're going to take an extra FANSCA trainee. Well, how will this influence our GPA trainees? And do you know what? The regional health services need more doctors just as much as everywhere else. And at the moment, we're not seeing it as an issue, but we're just building our relationships with those regional centres to make sure that we're training both. And if anything, by having more specialist trainees in amongst our GPAs, we're seeing more educational opportunities for our GPAs as an example, but any of the advanced training, they get exposed to more education. So it's actually complementary.
Sky,
Yep, Sue?
My comments would be that at the moment, rural generalism is quite heavily supported at both levels of government. Both federal and state governments are really keen for this program to be successful. I would agree very much with Angela's comments about support from regional hospitals in some circumstances actually increasing. And I think that's shown with some of the positions where you might get a smaller regional centre like Echuca or Swan Hill engaged with Bendigo in providing the training for some of our RGs. And I think that there's certainly a lot of merit in experienced RGs being involved in that special skill training as well, because it's quite one thing to give an anaesthetic in Bendigo where there's a button on the wall and there's other people there, to be doing the same anaesthetic in a smaller centre like Echuca. And so making sure that people are really prepared for the work that they're going to be doing in the future, rather than being a competent base hospital registrar, are probably quite different things. And so engaging with the RGs and the smaller hospitals, having that experience that's not just in the base hospitals, is a really important part of rural generalist training.
Thank you, Sue. Anonymous attendee, thank you for your comment. You've asked a question in the chat. As a medical student, I'm interested in a couple of regions in the VRGP intern program. Any advice from the panel on picking a region? What should someone take into account when making this decision? And I think it would be interesting to hear perspectives from all of the panel on this, given that everyone brings a bit of a different perspective to the discussion. But maybe if we start with you, Dan, first, as somebody that made this decision more recently, and then we can hand it over to Sue and Angela.
Thanks, Guy. It's a great question. I think most importantly, for me, what was important is where do I want to live and which community do I want to serve? Where do I fit in? I've actually been to all of the regions, fortunately, by travel or work, and I chose to live in the Grampians and will do for the foreseeable future. And that was my main influencing factor. But some other things to consider also about the availability of the training posts that you seek clinically as well, which I'm sure some advice can be sought from the VRGP program. But even if a particular clinical skill is not delivered in the region where you'd like to live and work long term, there's certainly possibility to be supported to train in one area and eventually end up in another. So for me, it was about where do I want to live and work long term.
Thanks, Dan. What about yourself, Sue? What would you say?
So I think the first thing is to have a think about where you want to live. And I think that you need to think about that in terms of the training that you have as well. So there's not a great deal for anyone to be gained by you doing obstetric training if you're planning to work in a smaller town where there are no obstetric services. And similarly with anaesthetics, you might have an urgent care centre in your hospital. So certainly there's need for rural generalist training, but the ability to use those specialist skills, I'd not like to see them disappear if you've spent the time and the effort to do the training and develop those skills. So that would be the first thing that I'd be thinking about is what sort of size town are you thinking about? Are there some regions that you've got some preferences? These are the towns that you might find will suit your needs as far as professionally that's concerned, and then having a think about personally what are the things that are important to you. So for me, it was living north of the ranges and seeing some sunshine, and that's how we ended up living up in Echuca. Yeah.
Thanks, Sue. And Angela, what would you say?
So I agree in terms of where you want to live. One of the great things about rural generalism is lifestyle, that you're able to, although you do on call and things like that, we do live in some of the most beautiful places. So it's about where do you want to live, and also your family commitments as well. I will just throw in that, when we came to Mount Beauty initially, we thought we'd commit for 2 years because my husband wasn't sure whether he'd be able to work here. And here I am in my 10th year. I think he's more committed to the area than I am, and I'm very committed. So, opportunities arose for him that we never really knew were there. So I think being really open to what an area can bring to you. With professionally, completely agree. Sue took the words out of my mouth about you do need to think about what you'd like to do in a career, and does that match the town in which you're wanting to do? And I was going to use the exact same. So unfortunately, my town was one of the hospitals that lost their obstetric service a few years ago, and so I can't practice obstetrics locally anymore. But people say to me, do you miss it? And I say, well, actually, there's now so many more opportunities that have come available that perhaps wouldn't have happened in that environment. And that's another great thing about RG, is the flexibility, and what you can do with it, and you can adapt and you can change depending on what stage of your life that you're in. But yes, talk to all the regional coordinators, go and visit them, go and see where you'd like to live and give it a try.
Thanks everyone. And we've got a comment from Greg in the chat. Thanks, Greg, for joining us this evening, who says, make sure you also consider family needs in the location. So another hot tip from our RGs in the audience. Jasmine has asked a question: in rural generalist training, what is the likelihood of having to move around geographical locations throughout your training? E.g., could you possibly stay in the one town for the entirety of your training? Angela, what would you say to that?
So there are some places around where you can stay in the one place, and Sue's an example from Echuca is one place that you can go to as an intern and stay right through with all of your training. And there are a few of those locations across each of the different regions. So yes, talk to the regional coordinators to find these out. Depending also a little bit on which college you decide to train with, there are some different rural requirements, but most of those do have some considerations or various things that can be factored in as well. So the answer is yes, there are places that you can stay and do all your training there, but others not so much. You might need to go to both.
So Dan, would you like to make any comments around that, training in the one location versus having to move?
I think that even if there are rotations, often they're from to relatively nearby towns, so that it's not quite as onerous as having to, move hundreds of kilometres away. So, I know that there's a rotation at the moment that some of my junior colleagues do, sort of, that involves some time in Swan Hill, some in Echuca, and some in Bendigo. And whilst that might take them away from their family for their working days each week, it's not too difficult to commute backwards and forwards. But as far as being a doctor in the region is concerned in the future, the relationships that are developed with those hospitals, I think, will give them a really good understanding about where they might want to be working and what sort of work they'd be able to be doing.
Absolutely. Anything that you wanted to add, Dan, at all?
I think Sue said it. That staying within your region is often what is really the objective of this program here. While I acknowledge that Angela has said that it's certainly possible to do it all in one town, from observation and lived experience, it's those unique sites, such as Echuca, where you can do RG1 through to graduation in one site, are probably less common than having to move within your region. There's a reasonable reliance on the larger health services, large regional health services, to provide the advanced training posts, because particularly for those procedural skills, such as anaesthetics, obstetrics, and sometimes emergency medicine. So for myself, I'm a trainee within the Grampians region, but the obstetrics training within the Grampians region was essentially only offered at Ballarat Health Services within that region, but that's not where I want to practice long term, because that's not where my scope or plan is. So for me, it does require a little travel, but I've stayed and thankfully been able to remain within the Grampians region.
Thanks, everyone. We have another question. This one is a little bit of a spicy question, so I'm interested to hear the panel's thoughts. Of course, pay for junior doctors has been very topical in the news recently. Many will have seen that the AMA is supporting a class action that's being brought forward from a number of tertiary hospitals. That's not necessarily a rural specific issue per se, but there are a lot of myths and misconceptions out there and murmurings, and people don't know what the truth is. And one of those murmurings that you hear a lot is around pay for GP registrars and rural generalist registrars, and that there is a discrepancy between what you might get if you remained in the hospital system. And I was just wondering if anyone on the panel would like to comment on that, and perhaps any work that's being done around that area of interest.
Shall we hear from Dan as the trainee first?
What would you say, Dan?
Sure. I mean, entering into rural generalist training, you're moving from one modality of pay as a state-based health service trainee, which is a salary under an enterprise bargain award, into a myriad of many different options of remuneration. In Victoria, the majority way of employment at the moment is a contractor arrangement with a private practice, plus or minus an appointment at a health service, whether that's a fractional appointment or fee-for-service or visiting medical officer rights. So it's really difficult to compare the two remuneration strategies because they are so starkly different. But when speaking about a clear transition from state health service, if you work only in a private practice and don't provide any services to the health service, there can sometimes be a noticeable difference in the start of a registrar's pay.
Angela, it sounded like you might have had a comment to make.
Yeah, so I think it's very individual. So Dan is completely right. There's definitely a difference from working from a state award across to the national minimum terms and conditions, which is what in primary care. And I guess that's what we're really talking about here. It's when it's actually the primary care component of the training rather than, because obviously some rural generalist training is still done in the public hospital sector. So whenever you're in the public hospital, you're still under the award. When you move into primary care, you're under what's called the national minimum terms and conditions. And although Dan said contracted, I think he meant as a little slip, as in you're actually still an employee with that. Once you've qualified, you can become a contractor, but you're employee of that primary practice. But most of the primary care clinics are unable to provide maternity leave and things like that. So to answer your question earlier, what's being done in this space? So there is a lot of negotiation at the moment between GPRA, which is the Registrar Association, SA, the Supervisor one, AMA, and the colleges regarding a potential single employer model. So there is a lot being done in that space. And I think if you're interested, get in contact with those organisations to hear what's happening and get involved. So potentially it could be moving in the future. With regards to honestly what you earn, I think you need to remember what you're doing in a per hourly basis too. So this is a few years ago now, but I don't think it's changed too much. When I transitioned from the public hospital where I was an O&G registrar, I was working ridiculous hours. And yes, when I went into primary care and I worked lovely restricted hours with only one night on call, yes, I took a pay cut, but so did the number of hours that I worked was significant. Once you actually start doing, as Dan said, some procedural work, you do some on call and all those kinds of things, the actual pay is very, very comparable. But definitely if you worked in maybe a metro general practice, it would be quite different from a rural generalist trainee who's doing on call and doing some procedural work. Having said that, as a rural generalist now, a fellowed one, when I work in a public health in a hospital where I'm not a VMO, but where I go in, say, doing a shift at my local regional emergency department, I'm paid exactly the same as a FACEM if I did an in-charge shift, or as a senior, I get the same rate as the seniors. So rural generalists are respected as a specialist in our own right, and we're paid. There is obviously differences. Each health service has their own contracts with their medical workforce, but definitely in the area that I work, we are treated on par with the equivalent specialist. So it's pay for like work for what you do. But I'd be interested to hear Sue's experience in that as well.
So the first thing I would say is that the description that you've just given, Angela, is for those people employed through AGPT, where there are minimum terms and conditions, and we would have some rural generalist trainees in Victoria employed through other models. So the ACRM independent pathway or the RVTS, and usually those people would have negotiated a contract with their employing primary care service as well as their health service, and so that can perhaps provide a bigger percentage of their income at general practice level to them as profit, but probably also gives them less support in the practice compared to AGPT registrars, who get a significant amount of teaching and support from their GP supervisors in AGPT employment as part of their contract. So it's a full half day a week, almost, I think 3 hours a week in practice, face-to-face teaching for some of that time with your supervisor and on-site supervision. And that's not how RVTS and the ACRM IP necessarily work. Yeah, so you sort of balance out that need for on-site supervision and how confident and comfortable you feel starting off in primary care versus some of the perhaps slightly better paid models through other programs. The other thing that I would say is that I think it's a challenging time for general practice, having lived through these last, I think, 6 years of Medicare freeze, when general practice did in fact not have any increase in the Medicare rebate. And so for people who are in non-private billing practices, that meant no increase in income for many years. But as usual, practice owners still had to pay increased rents. Their staff wanted pay rises during that time. Some of their other services that they need to employ to keep practice running went up too. So I think that it's a challenging time for general practice. I think many rural practices probably privately bill at least some of their patients just to make sure that they can actually keep the practice running and remunerate their doctors at a rate that's acceptable. Yeah. So when you're starting off in general practice and only seeing a couple of patients now, which is what I would encourage you to do because it takes a while to get used to that, and you're being paid a percentage, of that, then obviously that's relatively low wage. However, well-supported job, and you usually get to go home in the evening and not be working nights/evening shifts, various other prolonged hours. So yeah, it's a bit of swings and roundabouts, isn't it?
Mm-hmm. Mm-hmm. Thanks, Sue. We've got a question from Molly in the chat. Now, for any medical students or pre-vocational doctors who might be able to see Molly's question and all of the acronyms in it, don't worry, the acronyms are also a mystery to me, but they will not be a mystery to our panel. So I'll do my best at asking the question. Is there any consequence of the order in which you do advanced training year, e.g. RG1 plus RG2, then your GP training PGY3 plus 4, then advanced skill year? And any consequence of starting in the RG program, then deciding just to pursue GP with VRhc or ACRM and not RG? So that's a lot of R's and a lot of G's in there. What do people think about that on the panel?
Isn't it confusing?
All right, so I think I will summarise a few of the little things here. So both, or you took it away, Sky.
Oh, sorry, I've already put it in the answer. There.
No, that's okay. So I'm just going to put a few different hats on here before I answer the question, because I think it depends from through which lens you're looking at. So both colleges, and I have had this conversation within the past week with both of them, encourage trainees to do their advanced skills later in their training. Okay, but it's absolutely, after you've done that PGY 2 year with both colleges, you're able to do it at any stage. And where you should do it is and I'll put my Angela hat back on, is now a very personal decision. You know, factors such as, am I going to have to move, as we talked about before? Maybe you're better to stay in where you were to begin with, do that extra year and then move. Or perhaps you might like to go and get some primary care experience because you're connected to a town, and then you need to decide, well, what does my town need? And then choose what advanced skill you'd like to do. So I think it's actually, although there's some benefits to doing it later, and that really is because an advanced skill is exactly that. It's an advanced skill, and depending on your level of confidence, your ability to work independently, certainly the further along in your training you are, some of those skills you've gained just through experience can be brought back to that advanced training year. However, everybody's different, and some people are very confident and able to do that at an earlier stage, so that's fine. So I think it's very personal. It depends on where you want to live, what you want to do, whether you want to move, what your family commitments are, although both colleges do encourage it later. Now, with the second part of that question, which was, can you decide to do whether the advanced year pull out or not? If you enroll in ACRM, it is the advanced year is compulsory part of your training. So you actually can't fellow without doing that. So you're committing to being a rural generalist, and ACRM, as Sue said, is everybody who graduates from ACRM are rural generalists. That's the definition. With VRHC, yes, you have the option of doing the 3-year program without the VRGP. Our advanced year with the funded advanced year programs with the VRGP are reserved for those undertaking the Fellowship of Advanced Rural General Practice, that extra year, and that's because it is RG funded position. So you can start in the program and still get some case management and perhaps not to decide, but if you want to go on to do that advanced year, you do need to be committed to doing the RG training. But Dan or Sue, anything else in that? I hope I answered the question.
So I've had trainees who've worked with me coming to me with already having completed their advanced skill, people who've taken time out in the middle of their primary care training, and people who've chosen to do training afterwards. And as you said, Angela, it very much is what suits them as part of their where they are in their life, else they've got to consider in that, whether they're family members, jobs, those sorts of things that have to be factored in. And my experience, obviously mostly with anaesthetic trainees, was that we were able to support them, and especially with the assistance of consolidation of funding at any stage, to be able to integrate into our team. Some people found it better to still be a registrar when they were having that consolidation of training, and then there were other people who were really raring to go independently without sort of without anyone hovering over their shoulder. But our hospital would insist that they basically had to become familiar with our hospital environment and demonstrate their competence despite having had the tick off from the college, just because it is slightly different experience to be working at a smaller hospital in the middle of the night doing an emergency Caesar, whether you're the anaesthetist or the obstetrician, and that sometimes it's nice to have that extra pair of hands with you, at least for the first few times. So it really hasn't mattered a great deal, and we've been able to accommodate all of those options. And I can't say to you that any one person was better or worse for whenever they chose to do that. It really was up to the person being really enthusiastic about making the most of those new skills that they had.
Thanks, Sue. Anything, Dan, that you wanted to add to that from a trainee perspective?
I agree with what's said. It's a personal choice and what suits the community. I'm doing my advanced skill training. This is my 4th year of practice as a doctor. So I essentially, using the terms PGY1 is the same as intern, it's the same as RG1. So I did my internship and then my 2nd year of practice, and I took a bit of a different route and sidestepped out of the program in a way and went up to a smaller health service up in Ararat, where some of my time there counted towards my training and some didn't, and I made that decision there. And now this year I'm effectively picking RG AST, which in my 4th year. So I've chosen to bring my AST earlier in my training. Why I did that was, number one, I wanted to get kind of all of my hospital appointed training all done in one go, and then essentially step out of the hospital system in that type of employment model. But also on returning to smaller service, ideally returning to Ararat next year, that town requires GP obstetrics services, and I thought that I could be a real value add in that town to bring that skill service there, and the current GP obstetricians can support me to further consolidate. One final thing that I would like to mention is that there are some other considerations around, I'll just have to be honest, around remuneration differences. So if, for example, you do your AST last, so you will have essentially finished your GP employment, whether that's a contractor employer that we're talking about, or employee, sorry, that we're talking about, moving back then to a role in the state health service. It's unclear which level within the pay scale you would be employed at. There's that would have to probably be a negotiation that VRGP could help you with. Alternatively, if you stay within the health system and exit, there's a clear progression of pay scale within that system. And that was an important consideration for me, planning around my personal finances and needs.
Thanks, everyone. I'm mindful that unfortunately we've come towards the end of our time. I would like to ask all of the panelists for one final thought, and it's Jasmine's question in the chat. So to finish on, if everyone could say quickly, succinctly, the first thing that comes to your mind, what is the most rewarding part of being a rural generalist? Maybe Angela, if we start with you.
You said one thing, Sky.
Yeah, you can only pick one.
For me, it is connection to community in all levels that has, not only in terms of seeing people from, delivering the babies and then seeing right through to palliative care, but also when I leave my practice, when I go to the supermarket, when I pick my kids up from school, you're a leader in that community. You don't take your hat off and leave it at work. It's who I am. I wear it every day and I love it. And I think it's an honour to be able to care for my community and to live there and be with them. So sorry, that wasn't succinct.
Thanks, Angela. Sue, what would you say?
Well, I was going to say relationships, but Angela already pinched that. So I would say the variety in the work that I've been able to do over the last 37 years, from lots of hospital work, ED, general practice, but also lots of education, which I've really enjoyed. And now doing some governance work as well, and advocacy for our communities and for our doctors. So it's never been boring. I think perhaps I'd really struggle to do 5 days a week in clinic work, but the mixture has been great for me.
Thanks, Sue. And Dan, what about yourself?
Literally my 2 points. I guess you're a specialist in do it all, and that that makes you the chameleon of the medical profession, that if you want to adapt your career in any way at any stage, you have the skill set to do so and apply in whatever rural community in Australia to do that.
Thanks, Dan. So I'd like to just take the opportunity once again to thank Angela, Sue and Dan for lending us their expertise tonight. Thank you so much. To everyone who joined us, thank you for coming and submitting your questions. An evaluation, because we know that you love surveys and emails with evaluations. An evaluation is coming to your inbox following this session. So please help us to improve these sessions by filling it out. We actually would really love to hear your thoughts about how these sessions can be more valuable for you. A couple of other notes: AGPT 2022 round 2 intake will commence in the next few months. There are some advanced skilled training posts such as obstetrics in Albury Wodonga Health that are currently being advertised. Angela, where's the best place to get info around positions that might be vacant?
Yep, so all the advanced skills posts across the entire state are being advertised at the moment, and the best place to go to is the VRGP website, which I popped up before, or they're also on the PMCV website, which is where the application portal is.
Perfect, thank you. ACRM will soon launch its RG100 program, so keep an eye out for information on that. And then also make sure you check our website for details of the next VRHC21 virtual speaker series session, which is going to be in 1 month's time, same place, and it's going to be on the rural medical workforce. So we hope to see you then.